Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular session, I'll be discussing the quiz which I have posted on 13th of May on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So on this Telegram channel, every day I am posting the quiz and on subsequent day, I am sending the explanation as well. So as a part of it, let me discuss the first question. Which of the following is not the clinical feature of the Brown-Sequard syndrome? The options are ipsilateral loss of pain in temperature at the level of lesion, contralateral loss of pain in temperature at the level of lesion, ipsilateral exaggerated deep tendon reflexes below the level of lesion, ipsilateral atrophy of the muscles at the level of lesion. So Brown-Sequard syndrome is a very important question, and in this particular session, all the questions are related to spinal cord disorders. So first of all, what exactly is your Brown-Sequard syndrome? Brown-Sequard syndrome, it is the one where you have the hemisection of the spinal cord. Okay, so half of the spinal cord is being transected. Now, in case of Brown-Sequard syndrome, you have to know the clinical features are classified into two types. That is, below the level of lesion, what will be the below the level of lesion? What will be the clinical features? And at the site of lesion, what will be the clinical features? So this is how the clinical features of the Brown-Sequard syndrome are being classified into. And again, below the level of lesion or at the site of lesion, again, we classify them into the one with motor changes, the one with the sensory changes. So even here, even at the site of lesion also, you have motor changes and as well as the sensory changes. Now, at the site of lesion, remember what will be the motor changes is the motor changes always at the site of lesion will be lower motor neuron signs, and below the site of lesion in the spinal cord, below the site of lesion, it will be always the upper motor neuron signs. So what will be that upper motor neuron signs? So if you see this slide, in the motor that is below the site of lesion, the upper motor neuron signs include presence of Babinski sign, clasp knife rigidity, exaggerated deep tendon reflexes, loss of voluntary power, and loss of abdominal reflex. And at the site of lesion, what did we discuss? That will be lower motor neuron signs. What will be that? So there will be lower motor neuron paralysis in the segment corresponding to the level of lesion on the ipsilateral side. So that will be at the site of lesion. Now, the next important thing you need to know is the sensory changes. Now, if you take the sensory changes, you will have at the site of lesion, you will have anesthesia on the ipsilateral dermatome. That is what you will observe as the sensory changes. But if you take the sensory changes below the site of lesion, ipsilateral, you will have dorsal column sensation lost, whereas contralateral, the spinothalamic tract sensations are being lost. Always remember, the spinothalamic tract sensations are being lost contralaterally below the site of lesion. At the site of lesion, you don't have the spinothalamic tract sensations being lost. Why? Because the spinothalamic tract, they cross in the spinal cord 2 levels above to the opposite side. So that is the reason why the contralateral side you will have spinothalamic tract sensation, and that too below the site of lesion. Now we will go back to the question. So if you see the question here, that is ipsilateral loss of pain in temperature at the level of lesion, it is a wrong statement. Ipsilateral, what is being lost? Dorsal columns are being lost. It is not the spinothalamic tract. Contralateral loss of pain in temperature at the level of lesion, right? So that will be the correct statement. That will be the correct statement. And ipsilateral exaggerated deep tendon reflexes below the site of lesion. Yes, this is also correct statement because there will be upper motor neuron signs. Ipsilateral atrophy of muscles at the level of lesion. This is also the correct because you will have lower motor neuron signs. Okay, so the correct answer, the question asked is which of the following is not the feature. So the answer is A here. Now we will move on to the next question. So if you take the second question, type of sensation lost on the same site in Brown-Sequard syndrome is pain, touch, proprioception, and temperature. So type of sensation lost on the same site in Brown-Sequard syndrome. What is that we have discussed? It will be the dorsal column sensation that will be lost. Your pain and as well as the crude touch and temperature, these are carried by spinothalamic tract. Spinothalamic tract sensations are being lost on the contralateral side, but whereas proprioception is the dorsal column sensation that is being lost on the same side in case of Brown-Sequard syndrome. Now, you see the next question. Which of the following is not the clinical feature of the extramedullary tumor? Early corticospinal tract signs and paralysis will be there, root pain, bladder involvement, sacral sparing. So, if you take in case of the extramedullary tumors, they are very close or they are very nearby the corticospinal tract. So, definitely corticospinal tract signs and paralysis will be there. And these extramedullary tumors, they cause the compression of the nerve roots, right? Because they cause the compression of the nerve roots, there will be also the root pain. And what about the bladder involvement? In extramedullary tumors, bladder involvement will be there, but it will be late. Whereas you take in case of the intramedullary tumors, the bladder involvement will be early. This will be the difference between extramedullary and intramedullary bladder involvement. But bladder involvement, though, definitely it will be there. But what about the sacral sparing? Remember, sacral sparing will never be there in case of the extramedullary involvement. In fact, in case of extramedullary involvement, there will be early sacral involvement, right? There will be early sacral involvement in case of the early medullary tumor. So this is about the features of extramedullary tumors. Coming on to the next question. Cervical cord injury does not cause Horner syndrome, loss of sensation over the face, spasticity of the foot, wasting with fasciculations of the lower limb. So just now we were discussing in the spinal cord lesions, what is that regarding the motor manifestation? At the level of lesion, right? At the level of lesion, you will have lower motor neuron signs. Whereas below the level of lesion in the spinal cord, you will have upper motor neuron signs. Okay, this is very, very important concept. Now, in cervical spinal cord injury, Horner syndrome will be there because cervical sympathetic chain will get damaged and thereby you will have the Horner syndrome. That is a true statement. Loss of sensation over the face, even this also will be there. Why is that there will be loss of sensation over the face? Because the spinal nucleus of the trigeminal nerve, it starts all the way from pons, it goes up to C3 or C4 part of the spinal cord. So there will be definitely loss of sensation over the face. And spasticity of the foot also will be there. Why? Because below the level of lesion, the site of lesion is where? In the cervical spinal cord. So below the level of lesion, you will have upper motor neuron signs. Spasticity is the upper motor neuron sign. You will have that in case of the cervical cord injury. Whereas you take wasting and fasciculations of the lower limb will not be there. Because the site of lesion is in the cervical spinal cord, right? And wasting and fasciculations, these are the lower motor neuron signs. And where will you have the lower motor neuron signs if there is cervical cord injury? You will have lower motor neuron signs in the upper limbs, not in the lower limbs. Okay, so wasting and fasciculations, they are seen in the upper limbs in case of cervical cord injury, but not in the lower limbs. The question asked is, which of the following is not the true statement? Okay, so wasting and fasciculations of the lower limb is not the feature of the cervical cord injury. So today's questions are mostly based on the spinal cord. The concept is very, very important regarding the motor manifestations. That is, at the level of lesion in the spinal cord, it will be LMN sign. Below the level of lesion, it will be UMN sign within the spinal cord. Whereas regarding the sensory manifestations also, at the level of spinal cord, remember, you will not have ipsilateral spinothalamic tract involvement. What is that you can have? You can have ipsilateral dorsal column sensations which are being lost. Whereas below the level of lesion, you will have the contralateral spinothalamic tract sensations being lost. So this is the today's discussion. Thank you very much. See you tomorrow again with the remaining part of the questions.